Okay.
Yeah. Good evening, delegates. Thank you for joining Shield Connect. And today we are back with Sam Suti ma'am, and ma'am is going to take a topic, management of recurrent UTI. So before we start with the session, let me give a little introduction of our page, Shield Connect, and then I will introduce ma'am. So this is our page shieldconnect.in, where you can find various sections are available. Blogs section, where you can find all the updated blogs written by the eminent speakers and doctors. Then we have a key opinion leader section, where you can find all the profiles of the doctors who are connected with Shield Connect. Then we also have a webinar section, so you can go on this webinar page and can check out today's webinar. And you can post your queries in this live comment section, so we can have a Q&A session with our speaker for the day. And now let me introduce our speaker for the day, uh, Dr. Swayamsuti ma'am. So ma'am is consultant obstetrician and gynecologist, laparoscopic surgeon and infertility specialist in Shanti Memorial Hospital, Rourkela from Odisha. Ma'am has done fellowship in minimal access surgery from Belgium, fellowship in reproductive medicine from Germany, and fellowship in fetal medicine. So, ma'am, we welcome you on our platform for today's webinar, and we are glad to have you on today's session, ma'am. Thank you so much, ma'am.
Thanks a lot. Thank you so much. Shall I share my screen?
Yes, ma'am.
Is it visible?
Yes, ma'am.
Is the slide changing?
Not yet, ma'am.
It's hanging, so. Yeah, now it's fine?
Yeah. Yes. Yes, ma'am.
Yes. So, very good evening to one and all. Thank you for connecting to Shield Connect, and thank you, Shield, for giving me this wonderful opportunity to speak on a very interesting topic that we all see in the OPD, and it is very, very important for us to know both the aspects, our gynecological aspect and the urological aspect, coming under urogynecology. So, recurrent UTI, as we know, it is a very, very common problem among females, especially much that we see in the OPD. So it would be wonderful to know the recent guidelines and the different and brush up our basics regarding UTI and recurrence. So going ahead without wasting much time, recurrent urinary tract infection refers to more than or equal to 2 infections in 6 months or more than 3 infections in 1 year. Recurrence can be due to reinfection or a relapse of persistent foci of infection. So we have two things in this one. We have a reinfection and we have a persistence of the infection. So most recurrent UTIs are thought to represent reinfection with the same organism. So majority of it is reinfection instead of the relapse of the persistence. So this is what we have to keep in our mind, that whether we are dealing with the reinfection or we are dealing with the persistence of the same infection. Symptomatic infections can follow complete resolution of a previous UTI. In a primary care setting, 53% of the women above the age of 55 years and around 36% of younger women report a recurrence within 1 year. As we all know, our stats may be different, but in our regular basic OPD, we would find much more percentage of women in this category. Hence, its management and prevention is of utmost importance for all the clinicians, including the non-specialists and those in the primary care setting. It is not only for the gynecologist or the urologist, it is for all the common physicians and others to know, because UTI is a very, very common thing and very carelessly treated, I feel. And that is the reason for most of the relapses, reinfections, resistance, and all the R's that you can think of. Important definitions coming to that, it can manifest as either cystitis, as we know, that is inflammation of the bladder, or pyelonephritis going upper the urinary tract of the kidney and the ureter. Complicated UTI, it is associated with a structural or functional urinary tract abnormality or an underlying pathology. both of which can subsequently increase risks of acquiring an infection or failure of therapy. So we need to differentiate also among complicated and uncomplicated UTI so that we can chalk out a plan regarding what would be our antibiotic prophylaxis or the course of treatment or the follow-up, or what kind of studies are we going to do or investigations we are going to do on the women. Uncomplicated UTI, it is a sporadic community-acquired episodes of cystitis and pyelonephritis in otherwise healthy individuals, but could lead to more serious outcomes and thus require additional attention. So we have to be careful about complicated UTI because there is increased risk of reinfection and failure of therapy, and uncomplicated because it may also lead to serious sequelae and other problems of pyelonephritis and cystitis. So it's not like we are not going to give much attention to uncomplicated UTI because of the term. Behavioral risk factors of recurrence. What are the risk factors that we are going to look in our history and ask the woman about it? Frequent intercourse, strongest risk factor, more than 9 times increases the risk, 10 times. The use of spermicides, the use of vaginal diaphragm, a new sex partner in the past year, and the age of the first UTI being less than equal to 15 years. So all these have been seen as the various risk factors which lead to recurrence of urinary tract infection. And what we find is postcoital is very, very important thing. We do not find much use of vaginal diaphragm or spermicides, but the early onset of UTI in less than equal to 15 years and frequent intercourse are one of the very, very important factors. Behavioral risk factors, again, what are the other things that we need to look into? There is no proven association between recurrent UTIs, pre or postcoital voiding patterns. So when it comes to pre and postcoital voiding, we do not find any relationship in it that we have to empty our bladder before the intercourse or after the intercourse. Frequency of the urination, the wiping patterns, douching, use of tight undergarments, delayed voiding habits. So these are the things which we have to look into. That is how frequently we urinate, what is the wiping pattern, is it from the urethra up to the back anus or from the anus back up there, or the douching technique, how we are doing it, what kind of undergarments, the material we're using, whether it's tight or loose, and what is the moisture content there, or what are the other infections growing there. And delayed voiding habits, many people have tend to not void very frequently, and all these are a lot of stagnation down there. So these are various risk factors that we need to look and try to extract in our history. So this is a wonderful figure that you can see here. Correct posture for emptying the bladder. We lean forward, arched at the back, completely relaxed tummy, head up, no footstools. Host risk factors for recurrence, factors causing immunosuppression like chronic renal insufficiency, diabetes mellitus, immunosuppressant medications, renal transplant, HIV, AIDS. I think these are the conditions which you find in all kinds of diseases. So that would be definitely in our mind for any infection. I think immunocompromised state is a reason. Nosocomial factors and instrumentation. Exposure to antibiotic resistant bacteria. Again, as we know that it is very carelessly treated, and every now and then we write a course of antibiotic for people for any kind of infection, and we know how we are dealing with it. It is we who are suffering in our OPDs when it comes to antibiotic resistance. Indwelling urinary catheter, intermittent catheterization, nephrostomy tube, urethral stent. These are the various factors that we can see post-operative and other issues that a woman has. We frequently find all these kinds of procedures being done where we leave the catheter. We need to do self-intermittent catheterization, SIC, or sometimes post-surgery, we have a nephrostomy tube, and urethral stent is so common in complicated surgeries. Host risk factors, again, for recurrence, mechanical and physiological factors affecting the bladder emptying. So what are they? Incontinence, cystocele, post-void residual urine. So increased post-void residual urine, which we always look for when we are doing an ultrasound, that is more than 50 ml, is an independent risk factor for recurrent UTIs in postmenopausal women. So it is very, very important when a postmenopausal walks in with an UTI or a recurrent UTI, we need to check the post-void residual urine. It is wonderful if we do a pre-void too. So more than about 50 ml, it is an independent risk factor. And others, as we know, incontinence, cystocele, are and obvious risk factors. Coming to relapse versus reinfection. Relapse is caused by the same bacterial strain implicated in a previous UTI within 2 weeks of completion of treatment for the original infection. So we have already treated the woman, and within 2 weeks, we have the same bacterial strain coming and causing a problem. So that is relapse. Coming to reinfection, it is a recurrent UTI arising for more than 2 weeks after treatment or after sterile intervening culture is considered to be reinfection. So after 2 weeks, we have done a culture, we found there is no growth or no organisms, and then we have another infection, so that is reinfection. So this is the basic difference between relapse of the infection and reinfection in terms of recurrent UTI, even if the infecting pathogen is same as the original. Factors predisposing to, so in short, I can say relapse is the persistence of the infection. Reinfection, no matter what the organism is, same organism or a different organism, but after a sterile culture after 2 weeks, when again a new infection comes up, that is reinfection. Factors predisposing to the treatment failure, I think that is very, very important here, that we need to know what treatment we are giving and why we are failing in it. Recent antibiotic treatment, hospital acquired infection, renal or bladder calculi, obstructive uropathy, renal cysts, renal diseases such as reflux nephropathy, chronic interstitial nephropathy, analgesic nephropathy, diabetic nephropathy, sickle cell nephropathy, and immunosuppression. So we have to look for all the nephropathies, whether it's a reflux or a chronic or an analgesic induced or due to diabetes or due to sickle cell or any immunosuppressed condition. So that are the reasons for treatment failure. Besides that, very obvious, any form of calculi in the renal or bladder, any obstruction or obstructive uropathy, any renal cyst, and we always have this thing that is antibiotic treatment very recently or resistance to it, and hospital acquired infection is a risk factor in all kinds of conditions. Pathogenesis. Bacterial strains are uniquely equipped with specialized virulence factors, different types of pili, which facilitate the ascent of the bacteria from the fecal flora, vaginal introitus, or periurethral area. So we have 3 areas in a woman, which, and as we all know, it's a short urethra, so there are more chances of it, and very close proximity to all these orifices. So there is an ascent of the bacteria up the urethra into the bladder, or less frequently allows the organisms to reach the kidneys. So this is how the mechanism is, how it travels, how the ascending infection happens in case of urinary tract infection. Coming to another important aspect that is very relevant to females or in our OPD, that is estrogen and recurrent UTI. We, as we know, a major chunk of them are postmenopausal that come to us, as we already mentioned, about 53% or 36% of younger women, and the major chunk being older women. So there is definitely an association between estrogen and recurrent UTI. The estrogen loss in postmenopausal women, it leads to decreasing glycogen, thinning of the epithelium, alkalization of the vagina, vaginal pH rises after menopause, and vaginal lactobacillus decrease, allowing gram-negative bacteria to grow and act as uropathogen. I think we all know this about the vaginal pH, as so many advertisements and all this are coming up to maintain the vaginal pH. And why is it important? All these changes change the vaginal flora and predispose to UTI. So we need to see what estrogen does, and then we can think of supplementation of the estrogen in certain cases. So the basic, as we all have to remember, glycogen comes down, epithelium becomes thin, the vagina is alkalized, the acidic pH is beneficial for us, the good flora, the good bacteria, lactobacillus come down, and the pH rises. So we need to combat all these factors. Cause of recurrence in low count bacteriuria or even negative cultures, answer lies in intracellular bacterial colonies forming biofilm. As we can see in this picture, that is a wheat germ agglutinin surrounding. Then we have E. coli with green fluorescent protein, and also we can see the host nuclei. So in the biofilm, we can see all this. This is the reason for the recurrence in low count bacteriuria or even negative culture. Because most of the times that we see that we do find a low count, we do find a negative culture, but not necessarily we do not have the infection. Depends upon how we are doing the test, what kind of procedure is used, what kind of media is used. Coming to biofilms, uropathogenic E. coli like E. coli CFT 073, UTI 89, and 536 invades the urothelial cells, lining the urinary bladder, which forms intracellular bacterial communities or IBCs or biofilm. This infection remains undetected in normal urine cultures and causes recurrence. These culture negative infections presents as unexplained dysuria and urgency and are termed as interstitial cystitis or bladder pain syndrome. So this thing that we can see, we do find so many women coming and typically telling us that we have pain there and all that. So when it comes to interstitial cystitis and this thing, we can find culture negative infections, because most of the time we don't even find pus cells and other things, but there is dysuria, there is urgency, and there is pain. So it becomes undetected in all these things. And so there comes the importance of biofilm or the intracellular bacterial communities. E. coli is the predominant uropathogen, as we all know, in around 80% of the cases, isolated in acute community-acquired uncomplicated UTIs. The others, what do we have? Around 15% we can find coagulase negative staphylococcus. Around 8% we can find Klebsiella pneumoniae. Around up to 8% again we can find Staphylococcus aureus. So E. coli, as we know, is the boss, is leading everywhere. And most of the times we do find it in our report. We sometimes find coagulase negative staphylococcus, we find Klebsiella pneumoniae, and we find Staphylococcus aureus. Group B streptococci, that is also 2 to 7%. Pseudomonas infections are relatively more common in patients with chronic catheterization. So we have to categorize our patients, saying what is the cause of the UTI, so that even if the culture doesn't come and all that, we know in our back thing, what do we have? We have someone walking down in the OPD, it looks like an uncomplicated UTI, we think of E. coli. When it comes to iatrogenic infections or some catheterization or something done, we think of Pseudomonas. That is how we are going to have it in the back of our mind and start our treatment. Proteus mirabilis is a common uropathogen in patients with indwelling catheter, spinal cord injuries, or structural abnormalities of the urinary tract. So Pseudomonas and Proteus these are the conditions where we can think of this being the causative pathogen. Assessment. Coming to the assessment, what are we going to see? The general or neurological examination, the renal size and tenderness, is the bladder palpable, and of course vaginal examination, whether there's some local cause or there's a prolapse or any other reason. So what are the investigations that we are going to go through? The routine investigation, of course, very, very simple, a urine dipstick test, which is not that specific and sensitive, but urine for microscopic examination and culture sensitivity is what we write rampantly to everyone. If systematic involvement is suspected, we do go for an ultrasound, we do go for an IVP, intravenous pyelogram, or a CT MRI. Recommendations for the imaging: there are no specific guidelines or indications for imaging studies in women who have recurrent UTIs. Indications for ultrasonography or CT may include all of this, that is a recurrent non-coital UTI. So we don't find any history of coitus and all, we can go for it when there is a recurrence, we can go for a CT scan or an ultrasound. Persistent hematuria associated with UTI, acute pyelonephritis, evidence of renal insufficiency. So these are the factors, these are the absolute indications where we're going to definitely go for further investigations like a USG or a CT. What are the various biomarkers that we can look for? A granulocyte colony stimulating factor, it may be increased. Macrophage colony stimulating factor, that also may be increased. What are the other things that may be increased? An interleukin 5, IgG, IgM, and an IgA. But we would find two factors decreasing here, that is PSA, prostatic specific antigen, and vitamin D. So this is what we're going to keep in our mind, that there would be an elevation of GCSF, MCSF, interleukin, and IGs, but there would be a decrease of a vitamin D and a PSA. And urine biomarkers, what are we going to look for? Interleukin 8 is going to increase, but NGF and NGAL is going to decrease. Serum biomarkers, serum antibodies were the first possible biomarkers found in recurrent UTI. The levels of serum antibody immunoglobulin, whether G, M, or A, in the study patients was significantly higher than those in the healthy controls. Serum hormone granulocyte colony stimulating factor and interleukin 5 at onset was significantly higher in the mice with redevelopment of cystitis than those without the reinfection. So we have studies which have proven that all these immunoglobulins and GCSF and interleukin 5 do have a role, and a very big role in case of recurrent UTI. MCSF or macrophage CSF was found to be significantly elevated in patients who subsequently developed recurrent UTI. Mean serum levels of vitamin D among premenopausal women with recurrent UTI were significantly lower than those of controls. Deficiency of serum vitamin D also might be a biomarker for recurrent UTI. So we need to check our vitamin D levels also, which is quite easy to go through in the OPD instead of these granulocyte colony factors and other interleukins and immunoglobulins, which are much specified tests. Urinary biomarkers, nerve growth factor or NGF, as already mentioned, there is a small protein that induces survival and differentiation of the neurons. Urinary NGF levels were significantly increased in women with overactive bladder and were considered a possible biomarker. So we can also look for a urinary NGF. Ideally obtained before and without delaying antibiotics is recommended in patients with recurrent UTI. It is recommended in A, pregnant women, B, patients with immunosuppression, C, urinary tract malformations, D, urinary tract stones, E, recent urologic instrumentation, F, indwelling catheters, G, neurogenic bladder, and H, kidney transplant. So again, repeating, as we know, this is very, very important, all these conditions that we are going to get in our head, which we have to look for in case of recurrent UTI and be very, very careful about it. That is pregnancy, immunosuppression, any malformation and stone of the urinary tract, recent urological instrumentation, an indwelling catheter, a neurogenic bladder, or a kidney transplant. Culture in the UTI, following bacterial counts are clinically relevant. More than 10 to the power 3 CFU per ml of uropathogens in a midstream sample of urine in acute uncomplicated cystitis in women. More than 10 to the power 4 CFU per ml of uropathogens in an MSU in acute uncomplicated pyelonephritis in women. More than 10 to the power 4 CFU per ml of uropathogens in an MSU in women or in straight catheter urine in women in a complicated UTI. So these are the various cutoffs that we can look for to have positivity in the culture. In a suprapubic bladder puncture specimen, any count of bacteria is relevant. So when we are doing an SPC, that is suprapubic catheterization, so any count of bacteria we find, that is where we go for positive result. In a complicated UTI, or we have given a straight catheter, then we have to look for more than 10 to the power 5 count colony forming units. When it comes to acute uncomplicated pyelonephritis, we have to look for more than 10 to the power 4 colony forming units. But when it comes to an acute uncomplicated cystitis in women, even more than 10 to the power 3 CFU in a midstream sample is relevant. Various imaging studies that we look for: patients with urinary outflow obstructions, systemic involvement with fever, fail to respond to antimicrobial therapy of 72 hours. These are the conditions in which we have to definitely go for an imaging study, but we do go for it even before that. So what are the imaging studies that we can think of? They are X-ray KOB, ultrasonography of the kidney ureter bladder, unenhanced helical CT, MRI, demercaptosuccinic acid scanning, DMSA scanning, excretory urography or an IVP, voiding cystourethropy or a cystoscopy. So these are the various investigations that are generally used in case of our recurrent UTI, or we have fever, we have hematuria, or antibiotics are not working for 72 hours. These are the conditions in which we have to go for these imaging studies. Coming to the treatment or the management part, as we all know, the first line is antibiotic prophylaxis, continuous antibiotic prophylaxis. There is another method, that is post-coital antibiotic prophylaxis. And of course, as we all know, most of the patients do this self-start antibiotic therapy. Ideal antibiotic for UTI, it should have an adequate coverage over E. coli. Concentration in the urine has to be seen, the duration of the therapy, whether 3, 5, or 7 days or even longer, low resistance, cost, low adverse effect profile. So these are the conditions that we have to look for in selecting our antibiotic. What are the various regimes that we follow in continuous antibiotic prophylaxis? Trimethoprim sulfamethoxazole, that is 40 mg and 200 mg daily or thrice weekly. Trimethoprim alone 100 mg daily, ciprofloxacin 125 mg daily at least, cefalexin 125 to 250 mg daily, nitrofurantoin 50 to 100 mg daily, norfloxacin 200 mg daily, phosphomycin 3 gram every 10 days. This is for recurrence. This is not for other things. This is for recurrent UTI, because usually we give a start dose of phosphomycin 3 gram, but when it comes to recurrence, it is nowadays being told that every 7 to 10 days you can repeat phosphomycin single dose 3 gram, that we usually give in our OPD also. Otherwise, we do have these other things which work wonderfully. Post-coital prophylaxis, within 2 hours of the coitus, we may give a TMP SMX of 40 and 20, 280 or 400, Ciplox of 125 mg, cefalexin again 250, nitrofurantoin again the same dose 50 to 100 daily, norfloxacin 200, ofloxacin 100 mg. The Infectious Diseases Society of America and the European Society for Microbiology and Infectious Diseases recommends the following, which we usually use in our OPD, that is nitrofurantoin 100 mg twice daily for 5 days, a TMP SMX of being 160 or 800 milligram twice daily for 3 days only, phosphomycin 3 gram single dose, as I said. For severe cases of recurrent UTI, these are the treatment options that have to be there in our mind. When we see E. coli, we can start off with ceftriaxone 50 mg per kg IV or IM. Pseudomonas aeruginosa, we may start gentamicin 6 to 7.5 mg per kg. Klebsiella, Enterobacter proteus, we may start ceftadizine 100 to 150 milligram per kg per day. Enterococcus, we may start ampicillin 100 to 200 milligram per kg per day. So these are the things that we can keep in our mind when it comes to severe cases for IV or intravenous prophylaxis. These are the wonder drugs which are going to work for these specific organisms. Estrogen therapy now. In 2008 Cochrane review demonstrated vaginal estrogen to be an effective prophylaxis in the prevention of recurrent UTIs. Estriol cream that we write very frequently in our OPD, that is 0.5 mg vaginally every night for 2 weeks and then twice a week for 8 months. Oral estrogen tablets are ineffective and also cause breast tenderness and vaginal bleeding. So we usually avoid the oral route for estrogen. We go for this cream or a skin use or cutaneous application. But here, vaginally, we can put it daily every night, 0.5 mg, then twice a week for 8 months. So that really helps in case of postmenopausal women, atrophic vaginitis, and the ones because of the decrease in the glycogen and thinning of the membrane and alkalization of the vagina, estrogen cream really works. Ascorbic acid or vitamin C, often recommended as a supplement that can prevent recurrent UTIs by acidification of the urine. Weak association, of course, not very relevantly associated. We can definitely give 100 milligram per day. Coming to methenamine salts, hydrolyzed to ammonia and formaldehyde when in acidic urine, which act as a bactericide to some strains of the bacteria. It has less side effects. A Cochrane review on the use of methenamine hypurate concluded that short-term use is effective in preventing a recurrent UTI. What are the newer antibiotics we have to see in the zone? Phosphomycin, of course, it's a wonder drug that we very frequently write. It's a new antibiotic that has taken up because of its single dose factor. It is a broad spectrum antibiotic produced by certain Streptomyces species and has bactericidal action. Coming to persistent acute pyelonephritis infection, generally IV hydration and antimicrobial therapy are followed by stepwise defervescence of approximately 1 degree Fahrenheit per day. With persistent spiking fever or lack of clinical improvement by 40 to 72 hours, urinary tract obstruction or another complication, it is considered to be persistent infection. So when we are having fever that is persisting, we are not having any improvement in the clinical symptoms in 40 to 72 hours. So we need to think of an obstruction or persistence of the infection. Causes of the persistent infection are urinary tract obstruction, as already told, abnormal urethral or pyelocalicial dilatation, intrarenal or perinephric abscess, nephrolithiasis. So these are the conditions that we find persistence of the infections. Any stone in our kidneys, any abscess in our perinephric area or intrarenal area. We have this pelvicalicial dilatation, which we see in many cases, urethral dilatation also, and of course, an obstruction in the urinary tract. What is the management of such kind of conditions, that is persistent infection? We go for a USG-KAB or one shot intravenous pilogram or an MRI. It may be used to detect the cause of the persistent infection. So what is the cause? Where is the dilatation? Where is the stone that is leading to all this? So that would be very, very clear when we do an IVP or an MRI. Obstruction relief is important. We need to remove the obstruction, whatever it is. One method is a cystoscopic placement of a double J urethral stent, a very, very common method that is used. Cystoscopically, a double J urethral stent is put in our ureter, so that it clears your obstruction. Percutaneous nephrostomy, of course, another important thing, and surgical removal of stones. Prevention of recurrence. Behavioral modification and avoidance of risk factors, very, very important. Even the voiding patterns, how we are voiding, as we already, the posture is one thing, but after that, how we are douching, the wiping pattern, so many other issues. How many times the lady, is there a delayed voiding, the water intake, so many issues are there when it comes to behavioral modifications, and we can prevent UTI. And it is our duty to counsel all the women in our OPD regarding these specific things, because of the ignorance of the women regarding how do they maintain simple perineal hygiene and voiding etiquettes. Non-antimicrobial measures like a cranberry juice or probiotic and hormone replacement in postmenopausal women, though they have very weak evidence in association, but they do work in many cases. Antimicrobial prophylaxis, of course. Prophylaxis with cranberry juice. Drinking cranberry juice might be the most well-known means of prevention. It is very popularized and very fancy thing that we find every now and then. We have pharma companies coming to us popularizing the cranberry extract. It has been shown to inhibit the adherence of P. fimbriated E. coli to urothelium and could decrease the virulence in bacterial cystitis. Early randomized controlled trials showed that cranberry juice decreased the number of symptomatic relapses over a 12-month period in women with recurrent UTI. So this is very, very important when we are talking about recurrence of the UTI. So there is a strong evidence that there may be a weak evidence when it comes to an acute case of uncomplicated UTI, but in recurrent UTIs, it has been proven that over a period of 12 months, we see that the cranberry juice and repeated intake of it, it has definitely decreased the symptomatic relapses. And as we have already discussed, the pathogenic pathogenesis or the mechanism behind how cranberry juice acts on the E. coli from being attached to the urothelium. With probiotics, how are we going to treat? Since the urogenital flora of healthy premenopausal women is dominated by lactobacilli, it has been suggested that restoration of the unhealthy urogenital flora from uropathogens with lactobacilli may protect against UTI. So we do write lactobacillus in these things that would promote the our normal commensal flora, which is very, very important. Promising result has been with intravaginal lactobacillus species daily for 5 days and then once weekly for 10 weeks. Hormone replacement prophylaxis, estrogens for preventing recurrent urinary tract infection in postmenopausal women, as we've already discussed the Cochrane 2008 database. Intravaginal estrogen therapy in the form of vaginal creams, ring pessaries significantly reduces the risk of recurrent UTI in postmenopausal women. Oral estrogen has not been effective to prevent recurrence. Vaginal irritation is the main side effect and might occur in up to 20% of the women. So this is a very, very important side effect, because people do come back to us when we prescribe an estrogen cream that it causes a lot of burning and vaginal irritation. Immunoactive agent prophylaxis, one of the most possible pathogenesis in recurrent UTI is adaptive immune response dysfunction, especially in defects of pathogen recognition. Thus, using a vaccine to strengthen the active acquired immunity against uropathogens might be a reasonable prevention of UTI recurrence. So as we know, there are so many immunomodulating factors and immunoglobulins involved in it. So we can definitely go for the use of a vaccine. Vaginal vaccine significantly reduces the risk of recurrence of UTI. It significantly increases vaginal and urinary IgG and IgA. A recent meta-analysis published in 2013 enrolled 4 clinical trials of an oral vaccine, that is OM89, and showed that it significantly decreased the rate of UTI recurrence. So this is something that we need to keep in our mind, and if possible, we can go for it. European Association of Urology Guidelines 2015 recommends the use of OM89 for immunoprophylaxis in female patients with recurrent uncomplicated UTI. So we can also think of this aspect or the spectrum of using OM89 to our patients, in which we do find that there is a rise in immunoglobulins. Antimicrobial prophylaxis, it should be used for after non-antimicrobial agents have failed. Antimicrobial prophylaxis for preventing UTI recurrence can be given continuously for long periods, that is either 6 months or 3 months. A Cochrane review found that postcoital prophylaxis was just as effective as low-dose continuous antibiotic prophylaxis in the prevention of a recurrent UTI. So it can be given a long term of 3 to 6 months or simply a postcoital regimen. So what are the various things that we see in postcoital? That is one-time dose. We have 250 of cephalexin, 125 milligram of Ciplox. We have 50 to 100 milligram of nitrofurantoin, TMP being 40, 200 to 80 sulfur methoxazole or 400. Norfloxacin again 200, which is same in case of continuous prophylaxis also. So what is the difference? In cephalexin, we may give a little lower dose, and others are mostly similar when it comes to daily and postcoital prophylaxis. Concluding all our talks, that we have spoken vastly about the various risk factors, the pathogenesis, the various the algorithms that we're going to do, in which case we're going to do the imaging, in which case we are going to simply treat it, what are we going to look in our history to know that what is the source of the infection, whether it's a nitrogenic or it is simply an acute uncomplicated one, is it a relapse or a reinfection. These are the various aspects that we've spoken extensively. I think if we have it in the back of our mind, we will be able to give specific and pinpoint treatment to our patients and not lead to complacence that we most of the physicians or most of the urologists or gynecologists have in treating a simple UTI, because it may lead to various complications. And we have seen people coming back with so many sequelae, with cystitis, with pyelonephritis and various other complications. And I think it is our duty to give quite a lot of attention to a simple UTI so that it doesn't lead to recurrence in other factors. A recurrent UTI might be one of the most common problems in urology gynecology clinics. Treating UTI might not be difficult, but preventing UTI recurrence sometimes might be very troublesome for both patients and doctors. Recent research has revealed many novel concepts in recurrent UTI, including the pathogenesis, risk factors, biomarkers, as I said, and also the vaccine. These are the few recent advances that we have spoken about, and the prevention, of course. Nowadays, recurrent UTI may be considered a distinct disease, and patients with recurrent UTI should be managed aggressively. Further basic science studies are needed to elucidate details in the pathogenesis, and RCTs are also necessary to clarify the efficacy of the current treatment. So there is no harm in trying different methods of it, but we have to be very particular about our antibiotic prophylaxis, and also keep in mind about the various other extra things that we can give depending upon the age of the patient, history of the patient, and the source of the UTI. So I think we have covered quite a lot, and I would like to give the to our Shield representatives to conclude the session and for discussion about questions.
Thank you so much, ma'am, for giving detailed information regarding recurrent UTI. So let me check if we have any questions. Give me 1 minute, ma'am.
Nishant, you're on mute.
Yes, ma'am. So
Yes.
we received one question. Can probiotic can be given to patient who have a recurrent UTI issue?
Yes, of course. I said it is like it may not give an acute relief to the patient, but definitely probiotics have a role in increasing, maintaining the vaginal pH and increasing the normal commensal flora or the lactobacillus in the vagina. They definitely have a role. Or if we can give a continuous, longer prophylaxis for up to 2 weeks of our lactobacillus species, that definitely has a big role. And intermittently, if we keep on adding our lactobacillus for 1 or 2 weeks, that is going to prevent recurrence of the UTI quite a lot.
Ma'am, is there any role of perineal washes that are coming nowadays?
Yes, it does have a role. I may not say that continuous use of it as most of the women are doing, but when we are having recently quite a lot of relapses or a reinfection, or we do find certain things, so maybe for a short term use, intermittently to maintain the pH. Perineal washes do have a role.
Ma'am, thank you for giving the answers to these questions. And we would like to have more sessions with you on Shield Connect. And
Thanks a
thank you
lot.
so much also.
Thank you. Thank you so much. Thank you.
Okay.
Thank you, ma'am. Thank you, Nishan.
8:30 8:30 के बाद आज ठीक है।